ruled out all those other things, and we recalibrated and all of that. So now, then we start to look at other things, because we have to, at some point, pick the number or figure out which number is really reflective of what's going on in the heart. And so we do things like hourly urine output. We look at an acid-base balance. We look at whether there's a base deficit, and we look at the lactate. Okay. And so we'll use these secondary things, and then pick one and go along that strategy. And if then, let's say the urine output drops, or your lactate starts to decline, your base deficit gets worse, then you pick the wrong one. You need to more aggressively figure out what is making the cardiac function inadequate. Okay. So, particularly for CABG, you want to maintain adequate tissue oxygenation. That's for all heart cases. You want to make sure that we maintain our coronary perfusion. So, the whole purpose of the heart is to deliver oxygen to the rest of the body. And there's two components of that. One is, do you have the oxygen to deliver, and do you have a good enough delivery system? So you can think of it like Amazon. Do we have the books to deliver, and do we have just a little dolly that some guy's going to run out to like through the neighborhood, or do you have a truck, or do you have a drone system that's going to for the demand of the body? Components of oxygen content: hemoglobin, oxygen saturation, PaO2. So what's the relation between hemoglobin and oxygen?
That's how your oxygen gets everywhere.
Okay, how?
It piggybacks on the hemoglobin.
Yeah, so hemoglobin binds oxygen. And how many, you guys know how many binding sites there are?
4.
4 binding sites. Okay, and that's the most efficient way. Now, there's also PaO2, which is free hemoglobin just dissolved in the blood. But you can imagine it's like if you're going to ship something, you're going to pack it in the boxes. I think the best. You're not going to throw random boxes everywhere in the truck. Okay? So these are going to be the most important components of your oxygen content. PaO2 is important in the sense because, here, okay. Right. This is the arterial oxygen content equation. So you can see hemoglobin and sat are multiplied by 1.36. So they're pretty important. PaO2, whatever that number is, you're going to reduce it by 0.3%. So that kind of the equation itself shows you how unimportant PaO2 is to the actual oxygen content. If you look at the hemoglobin dissociation curve, it is important because it affects the ability of hemoglobin to bind the oxygen. Where's that inflection point? So this is what we call a sigmoidal curve. You guys are familiar with that? Okay, so it's sigmoidal because it's S-shaped. And the important thing is, above it here, no matter how much you raise this, there's not much, how much you go out further, there's not much increase in the hemoglobin binding, okay? And that inflection point happens at 60. So above 60, you can do whatever you want to drive up your PaO2, but you're not going to get a lot more binding, okay? Why is that important? Well, increasing your PaO2 is cost, right? How do we, if we have a low PaO2 on the vent, what do we do? What are the vent changes you can do?
Increase the P.
Increase the P, and what's the other one?
Increase
Increase the FiO2, right? And both of those have bad side effects. Your P can cause barotrauma, and your FiO2 is oxygen toxicity, right? So that's when we get a blood gas, and as long as the PaO2 is above 60, 65, well, then we can leave the vent. This is, you're not going to get much more oxygen binding. You're not trying to aim for 100, right? Does that make sense? Okay. So if you have the oxygen content, how's your delivery system do it? That's your cardiac output. Okay, and again, that's the heart. So what's the equation for cardiac output? If you didn't see that, heart rate times stroke volume. Okay, right. And a lot of times, it's just heart rate times stroke volume, but we also think about heart rate and rhythm. Okay. Heart rate, post-op hearts, we can do a lot more than just like a random patient that came through the ED, because we have pacing wires. So we have the ability to manipulate both the rate and the rhythm with the pacing wires. And what's the best rhythm to have? Sinus rhythm, right? But let's say your sinus in the 40s, sometimes that's not as good as V-paced in the 80s. So sometimes if we come along and we see a patient who's very slow, that's the pacing, and try V-pacing at 80. And there's a trade-off. Why is sinus better than V-pacing? Atrial kick, yeah. So we don't know exactly what percentage that is for each patient, and so we do a little bit of experimenting to see what's better for the patient's flow. Now why, well, okay, so then the other component is stroke volume. That's really kind of where all of our skills with fluid status, inotropes come in, things like that. So the three components of stroke volume are preload, afterload, and contractile. Okay, that's going to determine how much your heart can pump out. What's it? Anybody know the definition of preload?
The filling pressure, how much it takes.
Okay. So yeah, we refer to it sometimes as the filling pressure. The technical definition is the LV end diastolic fiber length, or LV. Now, those are not very practical things to measure, right? So left ventricle, because that's what's the main chamber that we're interested in as far as function. End diastolic, so once it's full. Fiber length, well, you can't measure the fiber length practically, right? You have to stop the heart, cut it out, measure it in a microscope. LVEDV, you could estimate by echo, but that's not practical to have someone in the ICU sitting there saying, okay, yeah, that's good volume, no really too much blood, right? So we use our swan to estimate the pressure, and that tells you about where your preload is, okay? If you have a swan, we use the number, the best way is a wedge. We don't wedge here, most places don't wedge just because there are risks to it. So we use our PA diastolic as a filling pressure, okay? So that's important because a lot of times they call, the PA systolic is this. I don't really care that much about the PA systolic or even the mean. I really just care about the PA diastolic because that tells me the filling pressure on the left side. Okay? If you don't have a swan, then you use a CVP. But how do we use a CVP and PA diastolic in conjunction? What tells you which? What tells you what?
So CVP is right, PA is left. So if your CVP is really, really high, it's your side, like right side problems.
Yeah. So remember I said that the right heart pumps to the lungs, the left heart pumps to the body. And it's all one organ, but we can think of it over, so you can have right heart failure, you can have left heart failure, you can have both, right? And so we want to really think CVP is reflecting our right heart, PA diastolic is reflecting our left heart, and that can help us diagnose the difference between them. We'll go over that later. Okay. So that's preload, or volume status. Afterload. So afterload is technically LV systolic wall tension. It's determined both by the preload and the systemic vascular resistance. I have to say, practically, we really just think of it as the blood pressure, what the heart has to pump against. So ideally, what would be the least stressful on the heart?
Low SPR?
Yeah, afterload of 0, right? So the blood would just go out and we're very happy. But that's not good because, well, why is it not good? Why is it not good for the body? Yeah, you need perfusion pressure to the other organs. And why is it not good for the heart to have that? Well, it's not going to go to the coronaries, right? Remember, the coronaries are reliant on that pressure to get filled as well. So they're like organs. Okay? So we'll go over more the blood pressure and things like that. So contractility, what is the definition is the intrinsic strength of the myocardial contraction. We use ejection fraction, we use stroke volume kind of to think about this. There are a lot of things that can change it. Have you guys heard of the Frank-Starling curve? Okay, anybody want to tell me what that's about?
Stretch and squeeze.
Yeah.
Sort of like the rubber band, if you stretch it out too far, it's obviously not going to pump effectively or stretch effectively and snap back into place.
Yeah. So you think like if you go to the gym, if you use a 2-pound weight, you're not going to get anything out of it. But if you use a 40-pound weight, your workout's also, well, I took a 40-pound weight and tried to do bicep curls. That would also not work very well, right? Because I would fail pretty quickly. So there's an optimum range of filling of the heart where the contractility itself is going to be best. And that's independent from just your preload status. Okay, so like 3-pound weights for you. Grilled cheese. Okay, so then the other thing is actually the heart rate. You can think of this sort of like gas mileage, okay? Okay, so gas mileage, like your car does best at highway speeds. Above highway speeds, the gas mileage drops, right? In the neighborhood or whatever, suburban settings, it drops as well. So there's an optimum heart rate now. Immediately after surgery, we generally let patients be where they are unless it's affecting the index. The very, very high-risk patients, low EF, who do a big operation, cardiac function is marginal. We usually aim for a pace at 90. So it actually wants, it performs best if it's a little bit faster. In the long term for coronary bypass patients, we actually want the heart rate to be pretty low because the less times it beats, the less myocardial oxygen demand, right? But in the immediate post-op period, our priority may be contractility, cardiac function. Okay. So sometimes that's why we'll aim people at 90, even up to 110. Okay. So contractility also can be affected by acidosis, hypoxia, high PCO2, and medication. So these are other things that there's an opportunity to work on if you have a patient that has marginal cardiac function. Okay, so I get this question, where do you want your blood pressure on post-op patients? So what is the ideal blood pressure? Well, it depends, and it's a little bit complicated, but not too complicated. What would you guys say is the usual blood pressure that we're aiming for?
60 to 90?
Yeah, map 60 to 90, that's pretty good. Okay, so what's the problem with too much blood pressure?
Blow a graft. You can blow a graft.
Could be, yeah, okay. Yeah, because the graft is sewn on the aorta. And so if the blood pressure is too high, that suture line can combust open. I have heard of it happening. It's not happened to me yet, but that is a possibility. Also, I know this talk about cabbage, but diet, anytime we work on the aorta, sometimes the aorta is very fragile tissue. It tears easily, especially if a patient has just had a dissection. And so sometimes we may be aiming for a lower blood pressure, and we'll generally tell you this patient has bad aorta, let's keep the blood pressure on the lower side. What's wrong with too little blood pressure? Hyperfusion of the organs. What else?
Lose a graft,
Lose a graft, yeah. So consider the grafting organ. So then the graft goes down, and now you have acute ischemia. You're basically giving the patient an MI. Okay. So we get very in the cabbage patients, we get very concerned about blood pressure stuff. Okay. And then other. So these are like sort of emergency things right after surgery. So blood pressure control, that's why we want the range we want. What about tachyarrhythmias? Well, in general, so usually you're going to see AFib, RVR. Sometimes we'll see sinus tach. If a patient doesn't have coronary disease, and let's say they were young and came in for endocarditis, that's part of the SIRS response to having their endocarditis operation. And we're less concerned for those patients because they don't have coronary disease. And so their myocardial oxygen demand can be a little bit higher. But in a patient that had a cabbage, we really would like to keep that heart rate lower so that his heart, which is compromised, is not needing more oxygen. Bleeding. A lot of issues with bleeding. Do you guys have any questions about bleeding or comments about bleeding? Why does it happen? Okay. Yeah.
I had a question. So DDAVP, when we give that for bleeding, what part are we trying to affect with that? I mean, what does that affect as far as the bleeding goes?
Sure. So that usually improves platelet function. So even though sometimes patients have the enough platelets are not functioning. Okay. And it's especially true of patients with renal disease. The other thing is it's not a blood product. It's not like cryo or FMP. So it does save. If it's effective, then you can hopefully save the patient from having blood products transfused as well. Okay. So sometimes the reasons patients are bleeding after surgery, obviously surgical. We hope that's not the case. If it is, we take it back. And there's a little bit of an art to trying to figure out if that's the case or not. How much time do you have left?